Hello, I am going to apologize in advance for this situation going on here. You can thank my 1 and my 3-year-old for this parting gift that they gave me before I left New Orleans. I'm really, really sorry because I can't stand to listen to myself right now, so I can only imagine what this is like for you. I'm going to do my best. It's really hard to follow that. I feel so like, what in the hell have I been doing with my life? So thank you for that. We're going to talk about palliative care. So I'm going to start with a case that's actually been relatively formative in my own career that I've actually never spoken about publicly because it's kind of a hard one for me to talk about. But you seem like a trustworthy group, so I feel like now is as good a time as any to share this. And I have to tell you the year, because I was only 2 years outside of residency, so I didn't know what the hell I was doing. So you have to forgive me, because I make a lot of mistakes. So I got a call. There was a 93-year-old woman coming in respiratory distress. And when she came in, her vital signs were bad, and she looked really bad. She had a non-rebreather on. She was huffing and puffing. We got an EKG soon after she arrived, and it showed that she was in complete heart block. And of course, I'm freaking out because I've put 2 transvenous pacers in my entire career, both highly supervised. So I'm like, oh shit. And there's no residents there, right, because it's conference day. So I call a cardiology to come down and help me put a transvenous pacer in, and her sister-in-law happened to be there with her, and she tapped me on the shoulder and said, can I speak to you in the hallway? And I said, sure. So we got in the hallway, and she says, whatever you do, don't do anything too aggressive with her. And I said, too aggressive? What do you mean? She said, well, she's like a really bad quality of life. She doesn't really get out of bed anymore. She doesn't eat much. She was just admitted to the hospital a few weeks ago for dehydration because she's not really eating much. And I said, oh, okay, that's interesting. Thank you. So then I went back in the room because, I needed to put a central line in and a transvenous pacer and all those kind of things. So I ran back in the room, and I went to tell the patient how I was going to put the line in, and I touched her neck, and she slapped my hand away. And she motioned for us to put our hearing aids in, and I said, listen, I got to put this line in you or you're going to die. Do you understand that? You're going to die? And she nodded, yes. And I said, and you don't want this? And she shook her head, no, she didn't want it. And I said, but you understand you're going to die? She said, yes. And so we're all sort of at the bedside, and I was like, I guess, do you want us to just keep you comfortable? Is that what you want? And she nodded yes, and I was like, all right, here we go. Okay, that makes sense. The cardiologist signed off, and that was that. Except, of course, obviously that's not that, because I'm talking about it today. So then all of a sudden I'm looking at her and I'm thinking, but she's in distress. I have to give her something, right? I'd heard about morphine used for this purpose, so I gave her morphine. I literally just made up a dose. I had no idea how much to use. Never thought about this before. So I give her 1 dose, not anymore, because I don't want to be accused of killing her or anything. And then her daughter showed up. At this point, the patient is unconscious, and her daughter shows up. I didn't even know she had a daughter. And I go into the room, and I tell the daughter, I'm really nervous, and I tell her how her mom refused everything, but it's okay, I got it under control. I'm giving her morphine, and we're not gonna do anything, but she's gonna be fine. And the daughter's kind of looking at me like I'm crazy. She's clearly not down with the plan, right? I can tell. She's uncomfortable, and it's very awkward in there with her, so I do what any reasonable physician would do. I don't go in that room again, because it's really awkward in there, and I don't like that feeling that it gives me when I'm in there. So I avoid her, and then I go home for my shift, because it's emergency medicine. So after I left, she actually called the head of cardiology to come down and see her mom, who told her, oh my God, the emergency department is trying to kill your mother. And I know that he said that because he actually emailed me those exact words the next day. And he had her intubated. He had her taken to the cath lab where a transvenous pacer was placed. And she was admitted to the ICU where she died the next day on a vent with the central line, with the transvenous pacer, with all the pressors running and tubes in every orifice. So, okay, I'm glad to get that off my chest. So that case was deeply upsetting to me. I kind of wondered, this 93-year-old woman, this poor 93-year-old woman was so clear to me that she didn't want this kind of care. And then she ended up getting that exact care on the last day of her life and dying the most highly medicalized death that you can die, in this country. How could this have happened? I obsessed about this case. It's like all I thought about it. I'm like prone to rumination. I ruminated. I actually brought it to the ethics committee at my hospital to no avail. And I was just so angry at this cast of characters who had derailed my perfectly good plan. I mean, I was like so on it, right? I had such a great plan, and they had all screwed this woman. It was like all their fault, right? So I was like obsessed with this idea. And then, like, as I had more and more time away from the case, I was like able to actually reflect and be honest with myself that it was in fact me who had totally screwed this up, right? That if I was being honest with myself, I actually had no idea what I was doing with this case. And that I was in fact totally overwhelmed by the situation and completely unprepared to deal with all of the challenges that a case like this presented. Took me a long time to get there, though. So what are sort of the specific challenges that I was not prepared to meet? I can use the language now to describe this. At the time, I couldn't have. So identifying a dying trajectory. So I look back now and I think the sister-in-law was kind of telling me, if I had like known how to interpret this, that this patient was at the end of her life anyway, right? I got a lot of clues from that discussion, but I didn't have any of the knowledge to know what to do with that or to recognize that. I could have used that information to talk to the daughter, but I essentially just ignored it because I didn't even know what it meant. And capacity assessment. So I think that this woman was fairly clear, and I think she understood what was going on, but this is a pretty high-stakes situation. It was life and death. Maybe she needed a more formal capacity assessment, sort of decision-making capacity assessment. We could argue that point. Honestly, if you think she should have, it wouldn't have mattered because I didn't really know how to do this at the time. I didn't have the skill set. And advanced directives, obviously, if someone has decision-making capacity, we don't need to assess for their advanced directives. That being said, it might have been helpful if I had known that she had advanced directives when the daughter and the cardiologist were there later to sort of support the idea that she meant what she meant when she said, to us she didn't want this care. But I'll never even know if she had advanced directives because it literally didn't even occur to me to ask about them. And difficult communication. It's really hard and awkward to talk about death or dying. The language is not intuitive. The wrong word choice can have a huge impact. And I had literally no ability to have a discussion about death or dying. I literally think, looking back, I never even mentioned to the daughter the words death or dying. I couldn't say them. I didn't feel comfortable. And when it comes to specifically withholding or withdrawing life-sustaining treatment, how do we present that to patients, right? How do we actually present the risks and benefits, and how do we describe what an alternative pathway looks like? Did I do that right when I said, okay, you just want us to keep you comfortable? Was that the right way to present that? I don't think so. And when someone decides to forego end-of-life life-sustaining treatment, and they have overwhelming symptom burden, what are the right medicines to use? What are the right doses? I literally had no idea. I was frantically looking it up on the internet, and I couldn't find anything, didn't know where to look, so I made it up. And the spiritual competency, this is a woman who knew she was dying. I'm sure she had spiritual needs. I didn't ask. I didn't even know to ask. I later found out that the daughter, they were both Jewish, and the daughter was fairly religious, and I wonder now if that was factoring into her decision-making. I'll never know, never thought to ask. And ethics, when we're faced with these very overwhelming end-of-life situations, is there an ethical framework that we can fall back on that can sort of guide us through the management? Well, of course there is, but I didn't really have one at my fingertips at that point, so I was totally lost. And then when we feel like we've really reached the limits of our knowledge base and expertise, are there systems of care that we can sort of rely on, consultants, a specialty perhaps, that may help us take care of people who are at the end of life? Sure there are. I was not familiar with them at this point. So sort of taken all together, what does this gaping hole in my knowledge base at this point in time represent, right? Well, this is palliative care, right? This is what I didn't know. This is the reason why I took such poor care of this patient. And you hear about palliative care spoken like palliative care is care that improves the quality of life of people who have a serious illness. Right? That's what palliative care doctors say. And people are like, what is palliative care? That makes no sense. It's so nebulous. This is palliative care, right here. So I was totally disturbed by this case. I was actually thinking about quitting. I was like, I can't do this job anymore. I suck at it. And then I actually came across this concept piece in Annals of Emergency Medicine in 2009, the same year. And it was introducing the specialty, this new subspecialty of palliative medicine to emergency doctors and saying, this is what it is. These are the domains, the ones that I just listed there for you. What we really need are some people in academics to go out and do this fellowship training and then bring this knowledge base and expertise back into emergency medicine. And I was like, sign me up, please. Like, this is what I need. So I went and did a fellowship, and I'm a better doctor for it. But is it just me, right? Is it just that I slept through all of the palliative care lectures that were given when I was a resident, and I missed all the lectures that ACEP and SAEM have devoted to palliative care, and the rest of you actually feel really comfortable with palliative care topics, and you're really competent when it comes to the end-of-life needs of your patients? You're really good at it. It's just that I suck, and all of you are really great. So the literature tells us a different story about that. So I love this study. I love it. So they audio recorded attending hospitalists talking to their newly admitted patients, and they were looking at the topic of code status. And it's not surprising that they actually don't often address the issue of code status, even though the majority of the patients in this study were seriously ill. What's interesting is what the content of that discussion looked like. They never talked about the patient's prognosis. They never talked about the likely outcome of a resuscitation, right? What did they really talk about? They talked about the procedure of CPR, because that's what we care about. Like, we really love to talk about the chest compressions that we're going to do in the breaking of the ribs, right? So they really talked about that, and that was really it. No one gave a recommendation, and the median duration of the conversation was how long? Shout out some numbers. 3 minutes, 2 minutes. Keep going. So it was about 1 minute was the median duration of that conversation. The conversations were bad. They were brief, or they were non-existent. Surprising? Right? So there's a study out of the UK in an ED there. Researchers actually just kind of sat in an ED for a long time, hours and hours and hours, and they observed the care of people who were at the end of life, either at the end of a long terminal or chronic illness, or at the end of like a spectacular episode like a trauma. And they looked at how those patients and their families perceived that care and how the staff perceived that care. Are you shocked that we were like rah about the trauma death? Everyone was like talking about it all day, like it was the coolest thing that ever happened. And the people that were dying at the end of a terminal disease, they actually got quotes from the patients and their family members. They felt neglected, less, uncared for. They felt like lower class citizens in our environment. And they interviewed the staff, and the staff's like, yeah, what the hell am I supposed to say to those people? Like, I have no idea what to say to them. This is weird. Why are they here, right? It was a lot of that. And then there's a study from JAMA, interviewing family members who had lost a loved one in the previous year, and they were asking them to describe and rate the care that they had received at the end of their life. And the patients had either died in the hospital, in the nursing home setting, or at home with hospice. And compared to people who had died at home with hospice, patients who had died in the hospital, their family members said they were treated with less respect, and they rated the overall quality of the care as worse. Surprised? Are you surprised? So, in fact, I don't think it's just me. I think we all really suck at this. I do. And me too, right? You saw it. Look at the care I provided in that first case, right? I don't think it's because we're bad people. I think we were never taught. No one really emphasized this when I was a resident. No one taught me. So how did I learn to talk to people at the end of life? Well, I modeled other physicians who were doing it terribly, right? So I modeled their bad behavior, and then I did my own bad behavior, and the residents watched me, and we sort of like perpetuate this endless cycle of bad behavior. And some of you in the room might be thinking, okay, this sounds like an American problem, Like, these Americans, they're crazy. And all these patients, like, it's because, like, Americans can't accept the part that, like, dying is a normal part of life, but we're much more evolved in Europe and these other areas of the world, and so, like, our patients don't do this. And you're right, like, this is an American problem. We have a real problem in America. We have a lot of problems in America. This is one of them. So this study is one of those studies, you don't have to read it, like, literally, that's the whole study in the title. So this is the problem, right? This is a huge problem. But I have looked at your literature, okay? And so this is a study out of Australia from 2011, and it turns out you have this problem too. So 65% of patients in Australia who have an advanced, like chronic illness like dementia or cancer are dying in the hospital or the ED, and they're visiting the hospital like 8 times in the last year of their life. And this is from Canada, and this is from Ontario, telling us that of patients who die of cancer in Ontario, 1/3 of them visit the emergency department in the last 2 weeks of their life. I don't even think we have that problem in America. Okay, so this is relevant to all of us, right? We all see these people, and we always will. And I tell my colleagues that because, like the response is typically like, as only we could like beef up the like discussions that they have with their primary care doctors. Like it's the oncologist's fault, it's the primary care doctor's fault. We need better access to advanced directives. Like sure, that all matters and we need it. You'll still always see these people, right? You are always going to see these patients. There will always be tragedies that people can't even predict or plan for. So you will always see these people. They will always be relevant to us. So what are we going to do about it? So you might say consult palliative care. And if you take that message away, if that's all you take away from this, like if you decide to go to sleep at this point, that's okay. Like that is okay for me if your response is, okay, I get it, I'm bad at this is relevant, I will call palliative care early and often for my patients who are at the end of life or when I feel like I've sort of reached my limit. You should. Particularly if you have a robust and readily available palliative care department, particularly one that would be willing to come in, on a Sunday night at 2 a.m. To tend to your patient's end-of-life needs. I worked at a department at Mount Sinai. It's one of the biggest and oldest palliative care departments, I think, in the world. We had over 20 palliative care physicians. We did consults between 8 a.m. and 4 p.m. on Monday through Friday, thank you very much, and on a very limited basis on the weekends. So if you had a palliative care emergency outside of those hours, good luck. And then there's another problem, which is, and I can only speak to the U.S. on this, in the U.S., only 2/3 of U.S. hospitals even have a palliative care department of any sorts. And that might be a nurse practitioner and a social worker, and that's the whole department. And that's bigger hospitals, right? Smaller hospitals, the numbers are much worse. And you might say, but yeah, like everyone's so excited about palliative care, so that's gonna change. It's actually not gonna change. We actually, at this point, need 18,000 palliative care physicians, and there are 3,000. And we graduate 260 from fellowships every year. Oh, and by 2023, half of the palliative care workforce is set to retire. So there never are going to be enough. The solution to this problem is not that we're going to have a bunch of palliative care specialists to come in and see our patients and tend to their end-of-life needs. And there's been a lot actually written about this in the palliative care community at the leadership levels, that yes, we need more palliative care doctors, and that is a priority, but that's actually not going to be the solution. So what is the solution? Just to bring this back to America. You like that? Okay, so this is the thing, right? So you're the solution, obviously. Because, so you're not a cardiologist. Unless, are there any cardiologists here? I apologize if there are any cardiologists here. I don't think so. So you're not a cardiologist, but you can read an EKG, and you can manage most of the common dysrhythmias. And you're not an OBGYN, but you can actually manage most first trimester obstetric complications, and you're not a radiologist, but you can use ultrasound for pretty much everything at this point. And you're not a palliative care doctor, but we should have a basic palliative care skill set to manage the more common end-of-life emergencies that we can expect to see in the ED and the ICU, right? Can we all agree on that? That our patients deserve that? They deserve that level of respect from us. And so what are we going to do about that, right? How are we going to bridge that gap between what our patients need and the knowledge base that I suspect currently exists in this room, which is pretty shitty? So one idea is, no offense, obviously, or anything. So one solution is fellowship training, and I don't mean fellowship training to increase the palliative care workforce. I mean, we need people in emergency medicine and critical care to go out and do a palliative medicine fellowship and then come back to this specialty, right? And then transform from the inside out. That's what we need. So if you are ever mentoring residents or registrars of yours who have a passion for this, you should encourage them to go out and do fellowship training. It's 1 year, right? It's obviously easy. They took They took me, so it's not that hard to get into. And then particularly if they're going to go back into an academic setting, right, they can change the curriculum, right? They can transform from the inside out. Once I'd done the fellowship and I stayed at Mount Sinai and I was working in both departments, I was able to create a mandatory rotation for all of our PGY3 EM residents. They all had to do a mandatory rotation on palliative care. And now we have one of our graduating fourth years doing another fellowship in palliative care because of his experience during that rotation. So we need more people to go down that road. Obviously, it's not for everyone. I would sort of direct that more at people who are sort of just coming up. But it's been recognized that not all of us are going to put our careers on hold and go out and do a year of fellowship. So there have been a lot of mid-career courses that have jumped in to fill this void. So there's actually a course called EPIC EM. This is specifically for emergency physicians. It's a train-the-trainer model. It's 2 days, 1 to 2 days, geared towards improving your palliative care skill set, just relevant to emergency medicine. And I believe at SAEM this year, they are offering a course on one of the pre-conference days. Harvard actually offers 2-day to 1-week courses geared towards clinicians of all types, just to improve your palliative care skill set and knowledge and sort of teaching you how to then leverage that into leadership roles in your hospital. University of Colorado just created, I believe, the first Masters of Science program in palliative care. This is a 1 or 2 year program you can do largely to be completed online with just 1 to 2 visits a semester on the weekend in person. Right? Again, they're sort of recognizing, gearing this towards people like you who want this knowledge base but can't take a year off and move to Colorado. And then something I'm very proud to be a part of, which is the Vital Talk group. So in the palliative care world, and that's Bob Arnold right there, he and his 2 colleagues are considered to be the gurus of communication. And they have created this experiential communication course. It's really focused on end-of-life communication. And they had a communication course for oncologists, for critical care docs, nephrologists. And we were very lucky that just in the last year, we have created the first Vital Talk course for emergency physicians. And we've adapted their model to emergency medicine. And we're hoping to offer a course at sort of the pre-conference days at ACEP and SAEM in 2017. And I understand for a lot of you, you're yeah, not going to happen. Not going there, not doing it. But I want to get better. The next time something comes up and I don't know what to do, what do I do tomorrow when I'm on my shift? So what you do tomorrow when you're on your shift is you go to this website. All right? This is your go-to resource, Palliative Care Network of Wisconsin, PC Now, Fast Facts. Fast Facts. These are amazing. There's over 300 Fast Facts that are written. They are these very brief clinical summaries of topics like, how do you talk to your patient about DNR? How do you do a death notification over the phone? How do you do event withdrawal, right? Everything that you need, clinically relevant summaries to be used at the bedside. I love this site. So, since I saw this patient in 2009, I have spent an obscene amount of time thinking about palliative care and learning about palliative care. And I recognize now that a lot of cases at the end of life are very complex, right, with messy family dynamics and external forces making it very hard sometimes to simply do the right thing, to align a medical plan with the patient's values and goals. It's not even always possible, and I recognize that now, that the world is a very messy place with a lot of variables that I cannot control. But what is different now is me, right? I'm what's different. I get this right way more than I get this wrong now, and I am generally very proud of the care that I deliver to people at the end of their life. I make mistakes all the time, right? But I have never screwed it up so spectacularly as I did in 2009. I can say that. And you shouldn't either, right? This is too important. We're negotiating time here that is very precious, and our patients deserve better. And this patient, I think we can all agree, deserves better. I think one of the things that's illustrated by a case like this is that when you screw it up at the end of life, your patients don't often get a second chance. I think fortunately we do, but we shouldn't let it go to waste.
Thank you, Ashley, for such an inspiring talk. Maybe we have time for a quick question, a quick answer.
Quick question. Lots of comments coming through about people finding it difficult to have end-of-life conversations or conversations where we're limiting or withholding potentially care. If you had one tip for people to improve their ability to have that conversation, what would it be?
One tip. Oh God, it's hard to have one tip. I mean, I would say one of the things I do now, particularly if you're in like a resource limited setting, you don't have a lot of time, is I sort of screen for whether that is a patient or a family that's actually ready to make that kind of decision, rather than investing the 20 minutes that you're going to need to have that conversation. So starting with something very simple like, I'm so worried. I'm so worried about your mom. I think your mom's really sick. Or what do you understand about your mom's illness? Or something like that. And sort of listening to what you get back and then deciding on based on what you're hearing back whether this is really a patient or family that's even ready to sort of make that kind of transition, I think is one of the more important things I do at this point. And I think in terms of the specific language to use, I don't think I could sort of summarize that in one tip.
Wow,
Thank you.
thank you.